good afternoon or evening, wherever you are, or maybe morning. Medoc is again very excited and extremely honored to host the second session of the 3-webinar series on the use of QST in clinical pain practice. The distinguished team of pain specialists from Leiden University Medical Center in the Netherlands are the experts who will share their scientific and clinical expertise on this subject. Last week, we've had the pleasure to hear Professor Albert de Haan on the scientific background of QST use in clinical pain practice. And you may find a recording of this webinar on our website in the recorded webinars section. This week, Dr. Monique van Velzen will speak of the practical aspects of QST testing. A few short notes for today. You may notice that you're muted. We welcome your questions very much. Please ask them in the Q&A panel of your navigation bar. We will try to tend to them all, but time constraint may limit us. If we haven't tended to your questions, please write to us so that we can try and answer them after the webinar. And finally, you will receive the recording of this webinar after we've processed it to the email for which you have registered. Dr. Monique van Velzen, the stage is yours.
Good afternoon, everyone. Welcome to this second webinar on quantitative sensory testing. My name is Monique van Velzen. I am the manager of the Pain Research Unit at the Department of Anesthesiology in Leiden University Medical Center in the Netherlands. It is a great pleasure to share with you a more practical guide on quantitative sensory testing, or QST. My talk will have the following outline. First, I will briefly go into the peripheral nerve fibers, the different types of nerve fibers, and how we can test them before familiarizing you with the actual tests that we perform in our clinical pain research unit, to close off with how you could actually use the outcomes of these sensory tests. First, I show you a simplified graph of the pain pathway, which might be familiar to quite a lot of listeners, just to demonstrate you that the actual pain experience is a complex array of stations within the body that start at the periphery, here depicted as number one, where there is a site of injury, and the actual information that is sensed there will be transported through the spinal cord up to the brain, where the actual pain experience takes place. For this webinar, I will focus on the peripheral sensing, so the first relay station in the pain pathway. When we talk about peripheral sensing, we talk about nerve fibers, of course. This simplified version of the different types of primary neurons that convey these senses are depicted in this image. Different fibers take care of different senses. Roughly, we distinguish 3 different sensory nerves. They are called A-beta fibers, A-delta fibers, and C fibers. A-beta fibers are classically defined as fibers that transmit non-noxious mechanical stimuli, here depicted as a soft feather. These fibers are relatively fast, and they transmit the information at relatively high speed through the dorsal horn, where the information is further transmitted to higher brain centers. Secondly, we have the A-delta fibers that primarily transmit information on noxious mechanical stimuli. They are also relatively fast, as opposed to the C fibers. They are the thinnest non-myelinated fibers that are primarily responsible for information on heat and chemical stimuli. Because these fibers are unmyelinated, they are relatively slow. So as you can appreciate, we have different types of fibers that have different functions. And we also see that if we look at quantitative sensory testing, or QST, we see that different types of sensory test modalities have been developed to specifically look at the function of these different types of fibers. So for this talk, I will focus on these 5 commonly used sensory tests. We look at temperature detection, cold and warm, cold detection and pain detection for these temperatures, primarily looking at A delta and C fibers. A third important phenomenon is called paradoxical thermal sensations, where cold is detected as warm or vice versa. The fourth test I would like to show you is the wind-up test or temporal summation test. I will shortly explain to you how this test is done. And I would like to close off with a test that we call pressure pain test, which is primarily a beta test, looking at a more deeper sensing of pain. So what devices do we actually use to make sure to run these tests? So we use quite a large array of MEDOC devices to apply thermal stimuli, so cold or warm stimuli, and we use the algomet depicted here on the right to give a pressure stimuli. There are different types of devices. We actually use all of the ones that are depicted here. So we have the TSA2 here on the left, the white box, which is a relatively new device from MEDOC that can easily reach high and very low temperatures at great accuracy. There is the QST depicted here in the middle, which is designed for clinical use. So it's a more simplified device, but again, it's really accurate. And there's a larger device called the Pathway, which can also deliver a lot of highly specific thermal stimuli. Depending on the setting, you can choose the device which is most appropriate for you. The algomet device depicted on the right here is a device that can deliver highly accurate pressure stimuli by digitally measuring the amount of pressure that is being exerted. So this is just the rough devices. On the other end of the device, there is the probe or the thermode, which is a Peltier block that can transmit the temperatures. There are different varieties that you can use depending on the setting or the size of the location that you want to stimulate. There are devices that are thermodes that are also compatible with MRI, in case you're interested. We recently obtained the tiny thermode, which is depicted on the right over here. There's a separate webinar on the tiny thermode in case you're interested in the possibilities and the specification of this thermode. And we use it on the external genital female area to look at thermal sensing in really small areas. So this is the tiniest thermode that is available at MEDOC. Of course, it is important to realize where you want to use these thermodes and where you want to do your QST. The place that you choose will, of course, depend on the complaints or the symptoms that a certain patient is presenting with. So you could appreciate to follow, for example, the dermatome distribution as depicted here on the upper right, where you can follow the well-known dermatomes to see if sensing of thermal stimuli is abnormal in any of those areas. An alternative that may be overlapping is related to the actual complaints or the symptoms that the patient is reporting. So this will of course depend on the nerve damage or the neuropathy or the disease that the patient has. So you could choose to test, for example, bilaterally to see if there's symmetry between abnormalities. You could choose to test an affected area as opposed to a more control area in the same patient to see if thermal sensing or any of the sensory tests that you do are different from each other. And you can, of course, ask the patient to point at a location that is most painful to see if the sensing is disturbed in any of those areas. So where to use it is actually depending on the aim of your study and of course the practical possibilities and I would say the symptomatology of the patient. What is also a possibility is to choose several fixed locations to see if you can compare abnormalities between patients. So for example, if you study a patient population that primarily has complaints in the feet or in the hands, you can choose to test, for example, the face, which might be normal in this patient population, the hands and the feet, in order to see what the distribution of sensory abnormalities is like. This is most prominent most well known in the length-dependent small fiber neuropathy as seen in diabetes. But for other diseases, this might be less clear. So it's good to realize where you want to do your test. And maybe just as important is the readout. So if you do these measurements, of course, you can ask your patient how painful the actual stimulus is, or the test is. So frequently used methods are, of course, the numerical rating scale, which you can do verbally or written, where patients give a number, usually between 0 and 10, indicating the amount of pain that's being experienced by this testing. If you want to go more for a more abstract kind of scale, you can use the visual analog scales for a patient to rate the actual amount of pain. Especially with thermal testing, of course, you can use the actual temperatures at which patients indicate that they feel cold or that they feel cold pain in order to register this and to compare it between locations or between patients. Another device that is available through MEDOC is the COVAS, which is a computerized visual analog scale. The big advantage of this COVAS device is that you can track the actual pain experience by the patient in time. So the pain scores on this VAS scale are being reported live as temperatures are changing in your software, allowing you to not only quantify the amount of pain, but also quantify how the pain is changing in time. And finally, there's the ability to use a response button. So for patients that are able and understanding, and you can give them a button and they can just easily indicate if a stimulus becomes painful or if they feel anything at all. So without going into much more theory, I would like to show you some practical examples on how we actually do this testing in action. And again, I would like to use these 5 commonly used sensory tests to demonstrate to you how it's actually going in practice. So first, the thermal detection and thermal pain thresholds. In the MEDOC main station software that comes with the devices, there is a preset modality allowing you to set cold detection, warm detection, cold pain, or heat pain. The actual practicality of the test, so the way the test actually works, is quite similar. There are a few things that within the software you have to preset. So I show you here a table that is actually similar to the way it is presented in the MEDOC main station software, but I would like to indicate a few or highlight a few fields that are important to think about before running a test. So what you can see here are 2 sequences, sequence 1 and sequence 2. Sequence 1 is for the cold detection, sequence 2 for the warm detection. What we choose in our pain research unit is to choose a baseline temperature of 32 degrees. 32 degrees is supposed to be the skin temperature in the extremities. So the actual temperature of 32 degrees should not really be felt as cold or warm by the subject. The next row shows a time before sequence where you can actually set like a break time in order for you to explain the test, for example. And you can also allow a certain trigger to start, for example, only the test if you manually activate it. Then the next row, it says rate in degrees per second. It's actually a quite important field to realize the speed at which your thermode is increasing or decreasing temperature. I would like you to realize that if you change the rate of your temperature change, it will affect your thresholds and detection, pain and detection thresholds. You might appreciate that if you increase a rate of a certain temperature, the response time for your subject will decrease, but also the alarm signals that might be activated by the neurons that you trigger, the alarm rate could increase. We choose for cold detection, warm detection, cold pain and heat pain, we choose a rate of 1 degree per second. We have practical experience that this rate allows a good and reliable response of the subjects to indicate their thermal detection and thermal pain. We choose a temperature return rate of 5 degrees per second, which is rather rapid, in order to get back to baseline. The last row shows you the number of trials. As with all testing, especially experimental testing, it is sometimes important to repeat certain tests. Some subjects might be relatively unsure on what they're feeling, and especially in patients who have large abnormalities, nerves might sometimes do convey the signal and sometimes they don't. So just repeating the cold detection threshold, for example, allows you to give a more reliable estimate of the cold detection threshold within a subject. We choose to repeat these modalities 4 to 6 times. I would now like to show you how we actually perform these tests. In the next movie, you will see a subject that has a 3 by 3 centimeter thermode attached to the hand, and on the other hand, the subject is handed out the response button. I will show you the cold detection, warm detection combined test as we do it in our subjects. What is shown here is that the temperature is decreasing at 1 degree per second as soon as the subject feels the sensation of cold, and he or she will press a button. The test will stop, return to baseline, and the test will be repeated, in this case 4 times. After the tests, the thermode will immediately increase in temperature, and the subject is indicated to press the button whenever the warm temperature is being felt. In this way, you can easily and quickly obtain several cold detection thresholds and warm detection thresholds within a single test. What is important to note here is that in practice, the subject that is undergoing the sensory tests should not be able to watch the computer screen, as it is most important for the subject to just realize whenever the temperature is being felt without being informed on the actual temperature. We do paradoxical thermal sensations by alternating warm and cold testing and asking the subject to use the words warm and cold whenever such a sensation is being experienced. In this case, we don't give subjects a response button, because for this test we are primarily interested if the subject is correct in guessing the cold and warm temperatures. Especially in peripheral neuropathy, we see that subjects lose the ability to correctly classify cold as a cold sensation. And we see that the cold is actually being perceived as warm. So by doing a test as this, we can detect paradoxical thermal sensations. For cold pain and heat pain, the test is similar to the cold detection and warm detection, but we actually ask the patients, the subjects, to identify whenever the temperature is being perceived as painful. The other test I would like to demonstrate is the wind-up test. Wind-up test is a sensory test that assesses the escalation of pain perception when giving repeated stimuli. You can choose to give repeated mechanical stimuli, for example, using a pinprick, or you can choose to give repeated thermal stimuli by assessing the wind-up phenomenon or temporal summation when you give repeated stimuli. The test works as such. You first give a single stimulus, a short mechanical or heat pain stimulus, and you ask the subject to rate the pain, for example, using an NRS. Next, you will give 10 subsequent repeated stimuli at a frequency of 1 Hertz, where the subject should indicate the amount of pain that's being experienced by the final stimulus. By doing this, you can compare the amount of wind-up or pain facilitation that takes place whenever you give repeated stimuli. You can also use the MEDOC devices to deliver repeated, fast thermal stimuli, as depicted here in the MEDOC software. Finally, this is the device we use for pressure pain. Again, it's the Algomet device. You can use it on pretty much every location on the body. If you choose preset anatomical locations for the hand, we choose this area as it contains mostly soft tissues, and we can compare pressure pain thresholds between subjects and even between experiments or studies. We gradually increase the amount of pressure until a subject indicates that the pressure becomes painful. The device registers the amount of pain that's being delivered, and as such you obtain a pressure pain threshold in kilopascals. So now I would like to show you some of the readout or some of the outcomes that actually come out of these sensory tests. As discussed before, you can collect temperatures, or you can collect pain scores or at certain thresholds at which stimuli become painful. It is important to realize that these outcomes should be compared to normal individuals, normal sites on the body, and should be corrected for age, sex, and location, as these will differ between subjects. The work of the German group on neuropathic pain studies has done quite a lot of work for the most standardized QST tests to obtain normalized values. So if you have values of a normal population, you can appreciate or calculate if your subject falls within 95% of the standard population or is actually significantly abnormal. So this is the way we also look at our outcomes of our QST. So this is a print screen of the sheet in which we collect, for example, temperatures, in this case for cold detection threshold, warm detection threshold, and thermal sensory Lyman, which is the alternating warm and cold test that is used to detect paradoxical heat sensations. As you can see in the gray areas, we collect 5 thresholds for each test. And for the paradoxical heat sensations, we do 3 warm and 3 cold stimuli. So we have the possibility to detect maximum of 3 paradoxical heat sensations where cold can be perceived as warm. For the wind-up test, where we give repetitive stimuli, repeated stimuli, we collect the pain score after 1 stimulus and we compare it to a train of 10. And we repeat this 5 times. For our protocol, we usually decide to give the pressure pain 3 times in order to get reliable results, and we calculate the average. By then comparing these raw values to normal values, we can calculate a normalized standardized Z-score. This score depicts the distance of the individual compared to the normal population, where the 95% confidence interval will function as a border for significant abnormalities. So if a subject is completely normal, their value should be in between minus 1.96 and plus 1.96. If a subject is above or below these numbers, it means that there is a significant gain of function or a significant loss of function for this individual test. On the x-axis, each individual test is being depicted, and you may recognize some of them. So on the left, we have the cold detection and warm detection thresholds, CDT and WDT. And for example, all the way on the right, we have the pressure pain threshold, the PPT. So if a subject is more sensitive to pressure pain, he or she will have a gain of function. And in this graph, the specific test will show to be above 1.96. If a subject has a loss of function, so there is an inability to sense pressure pain, this specific data point will be below minus 1.96, and there will be a loss of function. So I show you here a profile of different tests. So there are more tests than what I've discussed so far, but I hope you can appreciate that this is a healthy subject and all tests fall within 95% of normal. No significant abnormalities. Which is different for this patient. Here you see two lines, a blue line and a pink line. The blue line is what we have called the control area. So it is an area on this patient where he or she has no complaints or symptoms, no pain. Whereas the pink area is the test area where pain symptoms or neuropathic symptoms were being experienced. I would like again just select a few tests to just demonstrate to you that by doing these tests, QST tests on different locations, you can see that for again the CDT and WDT, so the cold detection, warm detection, there's a significant abnormality in the test area. And the same is true for the paradoxical heat sensations, here abbreviated as PHS. So whereas the control location is actually normal, in the test location where the actual pain or neuropathic symptoms are present, their paradoxical heat sensations were being experienced. So we call this QST profiling, and it will help us to understand what the distribution of abnormalities is within a given patient. But as such, we can also compare different patients or different disease groups. So this is also what we do in our research unit. We study, for example, larger groups of people with peripheral neuropathy due to diabetes, and we study different locations. So again, diabetic neuropathy is classically length dependent, where abnormalities first appear on the feet, and as disease advances, these abnormalities spread to the hands as well, or maybe even more widespread. And in this case, we considered the face location to be a normal location. And by comparing the QST profiles of almost 50 diabetes patients, we can see if there are any trends in QST abnormalities on different locations between different patients. We can even look at those test abnormalities if we group them on the type of nerve fiber that they actually test. So you can see that some of the C fiber testing may be abnormal on the hand, while some of the A beta fiber testing may be abnormal on the foot. So as such, we can look at different tests, different locations, and different types of pain patients. And we believe that if we classify patients as such, we can understand more about their underlying disease, pathophysiology, but it can also guide the way how we should treat these patients. So I again show you here on the upper row two panels of two different patient populations. On the left, you see again the diabetic neuropathy patients, and on the right, you see a QST profile of over 40 neuropathy patients that suffer from sarcoidosis, which is an inflammatory disease resulting in neuropathic pain as well. I will not go into all the details, but I hope you can appreciate that these profiles might look pretty different between patient populations, whereas some tests may actually be highly similar, especially when you look at specific locations. The lower graph shows you the amount of paradoxical heat sensations that are being felt by these patients. So blue are the diabetes patients, and in orange the sarcoidosis patients. And just to give you an indication, on the foot there is an equal number of patients that experiences paradoxical heat sensation if you compare diabetes to sarcoidosis patients. Whereas for paradoxical heat sensations on the hand, this is more prevalent in a diabetic population. So by understanding the actual outcome of these QST tests, we can understand more about the abnormalities in a certain patient population, and we can also understand more on the disease pathophysiology, which may guide, of course, treatment modalities. So the way we look at it now is by doing QST, we can actually profile a certain patient and indicating their phenotype. By understanding the specific type of abnormalities, we can define subgroups of patients that have identical abnormalities. Again, we can understand the disease processes in these subgroups of patients, and this will guide therapeutic strategies, hopefully understanding better which patients benefit from which type of treatments. If you're interested in such QST phenotyping, please send me an email. I'm happy to tell you more about it. I would like to close off by giving you my conclusions. So I hope to have demonstrated that QST allows precise phenotyping of patients that can lead to phenotypical subgroups. Some of these QST tests are really easy to perform and easy to understand as long as you choose the right settings. The patterns that you observe by QST profiling can indicate general or more segmental changes within a patient. And again, defining phenotypical subgroups may require distinct therapies. And we believe that clinical data will lead the way to improved personalized pain treatments. And this final conclusion is an invitation to you to watch the final webinar of this series that will focus on the clinical application of QST and understanding which patient will benefit from which treatments. With this conclusion, I would like to close off this webinar. Thank you for your attention. Thank you for listening. And we will now open the floor for Q&A. Thank you.
Thank you very much, Dr. van Velzen. To all of our attendees, those that haven't asked their question yet, this is the time to do it. And I'll give the stage to Professor De Haan, Dr. van Velzen, Dr. van Niesters to start answering your questions. Thank you very much.
I would like to thank Ofried, as well as Dr. Monique van Velzen for an excellent talk. I really liked it. She showed us the practicalities. She explained the QST, and this is, our daily work, especially in the pain clinic. I would like to start with the first question that was raised today, a very interesting one, and it discusses the C-fiber abnormalities. And this anonymous attendee asked us if is there a relationship with autonomic C-fiber abnormalities as well. And as you all know, that in neuropathy, there's all kinds of autonomic dysfunction related to abnormalities in small fibers, one of them being the C-fiber. I can answer the question, but maybe one of my colleagues can answer that as well. Maybe Dr. Niesters would like to answer this one.
Of course, it's a very interesting question. So if you have C-fiber abnormalities, of course, also autonomic C-fiber abnormalities can persist. With the QST battery that Van Velzen just showed you, you cannot discriminate whether there are C fiber autonomic abnormalities. You need different tests for that. For example, heart rate variability or sweat conduction are tests to see whether there are C fibers within the autonomic system involved in the patient's abnormalities. So not the QST test that Dr. Van Velzen showed, but of course other tests are available to look at these C fibers. Very good question.
Thank you, Marike. The next one regards the wind-up phenomena. This, again, anonymous attendee asks us, for the wind-up measurements, which is the best metronome to use? The Korkma or the Korkma 1 or 30? Who knows this? To be honest, I have no idea. Monique, do you know that?
No, so I think this attendee is referring to the speed at which you perform the repetitive stimuli. So it is an excellent question because it's really important to accurately time your repetitive stimuli. So if you use a thermal stimulus, of course, you can program it in software, but if you use a more mechanical stimulus, you can use a metronome, of course. So I'm not an expert on the different types of metronomes. So what we usually use is a digital clock, which shows just the running seconds in order to attain 1 hertz, so 1 stimulus per second speed. But of course, you can use really detailed metronomes for that. So I cannot really answer the specificities on the specifics on all these different metronomes, but it's good to realize that you should have an accurate speed.
So
Indeed.
we need to realize, Monique, that we use a 1 hertz, 1 per second stimulus.
Yes, exactly. So if you increase your speed, it will change your summation. If you decrease your speed, you might lose the summative experience of the wind-up test.
So we're now at wind-up. So there is one other question regarding to wind-up, and that question regards the normal wind-up. And we've discussed it in our group many, many times. Is absence of wind-up normal? So if you start with a first stimulus, let's say a heat stimulus, and you get a pain response of an NRS of 2, and after 10 stimuli, again, it's 2. Is that normal? Or do you expect a small increase to, let's say, 3 or 4?
Yes,
I can answer this question. Oh, okay. So it's normal to not have wind-up. And there's a lot of debate in the literature on what an aberrant wind-up is. And the conclusion is not so easy, and we do not have a fair conclusion for this. But what the most studies use is that there should be a difference of 2 points on the NRS scale, from a scale from 0 to 10. So if you start with 1 and you increase to 3 after the 10 stimulus, or 4, 5, 6, etc., then you have a wind-up phenomenon. There's also some debate about whether going from no pain, so pain score of 0 to 1, is also a wind-up phenomenon. Some articles or some studies use this. We do not use this. We really want to see this increase of 2 points on the scale from 0 to 10, but it's still on a debate. But a normal wind-up is when there's no increase.
So if you have an increase of 1,
it's also normal.
That is considered normal.
Yes, that's considered normal. And if you have 2 points increase, it's considered as the presence of a wind-up phenomenon. And there's still debate whether from 0 to 1, so from no pain to a little bit of pain, is also a wind-up phenomenon. But we don't use it like that. We want to see a difference of 2 points.
And do we ever see a decrease over time in the wind-up? A decrease in NRS?
Not often, no.
But
just to add to that, a decrease in pain experience might result from the wrong speed at which you do the wind-up. So if you use a lower speed, you might get an adaptation phenomenon, and that might result in a lower NRS. But if you really keep to the 1 Hertz, so 1 stimulus per second, you would not expect a decrease.
So again, it's important to keep to the 1 Hertz, 1 per second.
Exactly. Yeah.
Okay, thank you. Great answers. The next question I would like to pose to you regards the paradoxal heat sensation. What is it? And is there a physiological understanding of this, in my opinion, complex phenomenon?
Yeah, so this is again a very good question, because also for this phenomenon, there is not a large consensus in literature on what actual paradoxical heat sensations mean. So the current view is that paradoxical heat sensations are a result of the heat sensing that takes over the cold sensing, and that it's not the result of apparent cold fibers. Although, like the graph that I showed you is highly simplified, so there might be overlapping fibers that detect, of course, both cold and warm. But the current view is that heat fibers start to fire when actually cold stimuli are being given. But yeah, it's really hard to study this in clinical practice.
And
that's
Monique,
the correct.
Is there a relationship between this paradoxical heat sensation and the concept of offset analgesia that we discussed last week, in which a reduction in thermal stimulus causes immediate analgesia, or not?
I don't think we ever looked at this, comparing this head to head. What we do see is that patients that report paradoxical heat sensations are usually patients that have quite advanced disease. So they might be phenotypically similar to patients that have a defect in offset analgesia. But I don't know for sure. So
and would you say that the paradoxical heat sensation is more related to the sensitization seen peripherally or centrally, or is it more a symptom of neuropathic pain per se?
I would say it is related to the peripheral sensing of the temperature. But we didn't, up till now, we didn't compare if it's really a central pain processing problem. We could study this, of course.
I understand. Is it quite prevalent? Do we see it quite often that patients?
Yes. So in some groups of patients, we observe this quite often, especially in the diabetic group. So they lose the cold sensation first, and what you see is that they, if you do like this sensory alignment, so if you ask them to report the actual temperature, they just feel cold as warm. So this is really clear in some subtypes of patients.
Very clear. Thank you. Well, now we have a couple of questions regarding normative values. The first one is from Jennifer Wright. She asks, when comparing two normative values, do we know the criteria on which the normative values were obtained, and how well do these values, or how well are these values powered per group, for instance, age groups, sex groups, etc. And that I find quite interesting, location tested, because we are now more focusing on testing painful locations, but I have never seen any normative values in that respect. For instance, the lower back in patients with low back pain.
No, so if you look at, so this is the German network on neuropathic studies. They did quite a lot of work to collect normal values of a subset. So I would just refer to these publications to watch the actual patient numbers. I don't know them by heart, but they did do quite a big attempt to collect a large data set. Of course, if you study different locations, different patient subtypes, indeed, as you mentioned, low back pain, or especially the use of the tiny thermode, on which there's very limited clinical or relative information of normal individuals, I would always suggest to include subjects in your study that do not suffer from disease, or to include a normal location in order to really determine if a value is abnormal.
What are you saying is that you need to create your own normal group or your own control group?
Well, I of course would love to see that there might be a bigger approach to collect normal values for all different types of locations. But if for the short run, I would suggest it's easier to just include a control group in your study that does not suffer from,
I
let's say, a
understand
low
that.
back pain disease. Yeah.
Like we do, yeah. And
Yeah.
there's another question in the chat, and that's an interesting one, about different ethnic groups. Have we ever done that?
Very, very good question. So I think different ethnic group, especially related to, so we are, of course, Caucasians in the majority of us. As far as our research unit, I think it's relatively understudied. So of course we have different ethnic groups, but we don't know for sure how these would impact the normal values or any of the.
I would like to jump in here because there are quite a few studies on different ethnic groups that where data has been collected on, for instance, Latino population, and these are studies that are coming out of the United States and Mexico, and I think there's also studies on Chinese populations. So a little bit of a literature search can yield something with specific on specific populations. Of course, in the Netherlands, there are different populations than elsewhere in the world, and that needs to be taken into account. But if you are specifically interested in specific groups, please write us an email, and I'll be happy to assist.
Great, thank you, Ofried. And then there's an interesting question, maybe Marieke can answer that. We talk about paradoxical heat sensation. And Lucian Macrea wants to know if there's paradoxical cold sensation, or is it the same?
Well, that's a very interesting question, because I'm always a bit surprised that there are only warm sensations, and I do not see them the other way around. And I'm not sure why this is the case, but we only see the paradoxical heat sensations and not the other way around.
When you give a cold stimulus, the patient senses it as warm. When you give a warm stimulus, they never sense it as cold. That's what you're saying.
Exactly, yes.
Yeah, so this might be related to an evolutionary advantage to keep on the warm detection, as it might be more threatening to your system, but at relatively low increases. So the cold, before cold becomes really damaging, you would need like really cold temperatures. Whereas for warm, even a temperature of 42 degrees might be damaging to your physiology, to your system. But this is just a theory, I would say. Yeah.
Very good, very good. Then there's a question regarding the QST and the pressure sensation, the pressure pain sensation. Could you determine the pressure sensation separately from all other QST? Well, I find this a very important one because it also interests me whether or not you can do a more compact QST battery rather than the complete battery of tests. What do you think?
So I think this is an excellent idea. So I think, you know, like all the information that we have on QST testing so far has been quite broad. So we look at different neurofibers, types, different symptoms. There are quite a lot of developments looking into more bedside QST. So looking at a selection of tests for which you know that they might be abnormal in your patient.
Mm-hmm.
So I would highly suggest to just select a test that will be relevant to you, to your patient, or to your treatment, kind of information that you want to have. But maybe Dr. Lies is going to add something to that for clinical application, I would say.
Yeah, I think to add is that you can perform every QST test separately. So it's not that you have to combine certain tests. You can choose them for yourself. And it's indeed true that there are a lot of shorter QST methods present. For example, also in patients with chronic pancreatitis, there's a publication on a short QST test. And it's, of course, very important in clinical setting where you do not have the time to do maybe 60 or 120 minutes of QST testing, but there's certainly availability of QST tests that only take you 10 minutes, for example.
Great. Now, this is a question that I find very interesting, and that is the use of QST in individuals that cannot express themselves. People with cognitive defects might also are in pain. And I know that people with dementia, Alzheimer's disease are also often in pain because they are unable to engage inhibitory controls. So the question is, how do you think QST can be adapted to populations that cannot verbalize that they're in pain? We have never done that.
No, so this is a very, very interesting question, especially because we know in these types of patients, pain is being underreported as a result of this. So there might be high suffering without actual knowledge of it. So I know that there are studies looking at facial expression, for example, or other types of expressions and movement of the body in order to interpret the amount of suffering or pain experience in an individual patient. But yeah, I can imagine that it's difficult. Same, of course, with small children, for example, that are unable to rate their pain. Similar kind of challenge.
Marieke, have you seen patients in the pain clinic that cannot express themselves?
Yes, of course, and it's very difficult because these facial expressions, which are also used, for example, in small children, we know that, for example, in patients with dementia, they don't work, they're not accurate. Well, in the QST test that we just showed, maybe some patients are not able to express themselves, but are able to use the button. So that's sometimes helpful if patients can say yes or no, or press the button when they feel something, or they need help. This can help. But if a patient cannot say anything or even not use the button, then it's hard. It's hard to see how much pain they are in.
Can I jump in and say that there are a few studies that have been done with people with cognitive disabilities in which they didn't use reaction time inclusive test, but they used the reaction time exclusive test of levels, also to test sensation and pain. So these are also maybe considerations in using the button, but not using the button in a timely fashion as we're used to from our healthy population.
Thank you, Ofried. Then there's a question about the application of cold and warm stimulus in the battery. Do we apply these stimuli randomly, the QST stimuli, or do we follow the same sequence every time?
Very good question if you talk about methodology and collecting sensing values. So in so we use a fixed sequence of testing. We believe that every test reports the perception or the sensing at that very moment, and there should not be any carryover. So we include ample time between tests in order to explain the next test, but also to give a subject a little bit more rest and to make sure that there is no overstimulation. So we use a fixed sequence, and as such, by performing it the way we do, we don't really think that there's carryover of any sensing between tests. But you should incorporate this in your protocol to be sure that the subjects don't become overstimulated, for example.
So are there pauses in between the tests?
Yes, absolutely. So the movie I showed you, that's quite a rapid test. So you do like several tests after each other. So but then we see that the actual temperatures that are being felt with each repetition, if a subject understands the test well, this is relatively stable. And we incorporate 3 to 5 minutes between tests. So if we change, for example, to a temperature pain test, we take a couple of minutes into account, of course, also to explain the test modality. So what do we expect, but also to give the nerves and the brain and just the subject as a whole, give them ample time to recover and to focus.
In our battery, Monique, we also have, of course, other tests outside of the QST battery, like the cornea confocal test.
Yes.
That prolongs the whole procedure even more.
Yeah, so I didn't show you, of course, a whole battery of tests that we use to profile our patients, but yeah, as Dr. Nies just mentioned, we might be using 60 or maybe even 120 minutes to really understand the full profile of a patient. So this is also sometimes quite exhausting for patients to know what are we asking, what should they report. So having enough breaks there is really, really important.
Okay, then again, I would like to go back to the normative values. We use normative values from the German group, but we apparently also use it on body areas where they haven't done the normative tests. So how do we know that these tests are within the normal ranges in our patients? We do not. I know that
Well,
we do not.
we always try to do if we do not have the normative values to make them ourselves, to use a healthy control group to interpret the data correctly, because it's correct that if you have the normative values for the foot, for example, and you measure the upper thigh, that you cannot compare them, but you can make an comparison to a healthy subset. So if you're really interested in a certain area of the body, you should make your own normative values within a healthy control group. And that's the best way to go forward.
Marieke, in the calculation of these normative values for wind-up, do we also measure the Z-score? I thought there we used a different technique. Maybe Monique knows that.
What do you mean by the Z-score?
No, the Z-score.
In the German network, they transform it into a Z-score, and I have to be honest that I don't know by heart what kind of transformation they use to get the Z-score for the wind-up.
This Z-score, yeah. So it's a log transformation. So they calculate the average and the spread.
The geometrical mean, and then they log transform. Correct.
Exactly.
Okay. Then I'm not sure if we still have time, or Fried. I think 2 more minutes. Then about the pinprick for wind-up, do we, for the repetitions of the pinprick, do we always use the same area of skin?
So we try to stay within 1 square centimeter of skin, just be sure to be in the same location.
Okay. Okay. Well,
and again, we have like a break of a minute in between to give the area some rest and the subject. Yeah. It's good to realize that you know, if you use a correct methodology, the quality of your data will improve. So these questions are all really important if you collect these type of sensory data.
Well, I would like to thank the audience because these questions were excellent. I'm really happy with today's lecture and today's questions. Thank you all very much. I think it's time to give the word back to Fried.
Thank you all very, very much for the very, very interesting questions. And if you have any other questions, please don't hesitate to write us, and we'll do our best to answer them to the best of our abilities. I would very much like to thank Professor Albert de Haan, Dr. Monique van Velzen, and Dr. Marieke Niesters for freeing their time again for this very, very interesting and important webinar. And I would very much like to encourage our attendees to come next week as well to the webinar by Dr. Niesters, who will discuss the clinical application and give some patient examples of QST data and the clinical reasoning behind pharmaceutical and other interventions based on QST data. So thank you very much for attending, and hopefully see you next week again.
Thank you.
Goodbye.
Thank you.
Goodbye.
Bye-bye.
Bye.